Hey, this is my clinical case presentation. TG is a 61-year-old white English-speaking female. She's a good historian. She's alone today for her visit. She's no longer employed. She's trying to get disability for her COPD and her hypertension. She's divorced, lives alone. She has 3 grown children, and Medicaid is her source of insurance, and she sees Miss Elliott for her primary care needs. Her chief complaint today is that it hurts when I pee and my pee smells bad. Her history of present illness is she has a medical history of urinary tract infections. She's recently noticed pain on urination and foul smelling urine. She says it started 2 days ago. She's experiencing urgency, but she does not say that she's experiencing any frequency. She says she's tried drinking cranberry juice at home, but she is not taking any over-the-counter medication. She does not report any nausea, vomiting, fever, appetite changes, weight loss, sleep disturbances, chest pain, shortness of breath, or chills. She does have a history of hypertension. She was diagnosed at age 47. Her current blood pressure today is 130/76. She does have COPD. She was diagnosed 5 years ago. She has GERD, diagnosed about 20 years ago, and she has had 3 cesarean sections. She does say that she has had all of her childhood vaccines. However, she doesn't have any of the records. She did receive the Moderna vaccine, 2 doses. Her last dose was in August. She did get the flu vaccine and a pneumonia vaccine this past year in November. She's unsure about her shingles vaccine, but she gets all of her vaccines at Walgreens, so she said she would call and check in on that. She has had a mammogram and a pap smear within the last year, and they were all negative. She's also had an EGD and colonoscopy, which they found nothing significant. And she is due for another colonoscopy, being it's been 11 years. So we will provide that referral to GI. Her social history, she's a current everyday smoker, 40-pack years history. She drinks socially, about 2 beers a week, she says. No history of recreational drug use or outside of the U.S. travel. She's divorced. She's not in a relationship. She attends church weekly. She says she's looking for fellowship and camaraderie. She does not exercise, and she eats a lot of fast food and microwavable meals since it's just her. Her family history, her father died of an MI in his 60s. Her mother died of gallbladder cancer at age 74, and her grandmother died of something respiratory, she's not sure, in her 80s. Her grandfather's health history is also unknown, but she thinks he had diabetes and heart problems. She did have a younger brother, which passed away in an MBA at age 36. She does have an allergy to sulfa drugs. She says it causes a rash. She's also allergic to cats, which causes itchy, watery eyes. Her current medication, she takes Prilosec for her GERD. She takes that every morning with her coffee, she says. She takes amlodipine, 10 milligrams daily, albuterol inhaler if she feels short of breath, which she uses it about once a week. She takes aspirin, 81 milligrams daily, and she took all of her daily medications this morning before she came in. Review of symptoms. Generally, she has no fatigue, fever, night sweats, no headaches, eye pain, pressure, ear pain, tinnitus, hearing loss, nasal congestion, stuffiness, sore throat, or hoarseness. No cough, pain, breathing, no shortness of breath currently, no chest pain, palpitations, dizziness. GI, she has no nausea, vomiting, diarrhea, no abdominal pain, no blood in the stool, no change in bowel patterns. She does not, for GYN, she does not endorse any discomfort, odor, discharge. She still has her uterus and ovaries. She reports amenorrhea for years, and she does have hot flashes. She does report some generalized joint pain. She says it's worse in the morning, gets better throughout the day. No muscle spasms, no muscle pain. No reports of headache, numbness, tingling, burning, tremors. No excessive thirst or intolerance to heat or cold. No bleeding, no bruising. Skin-wise, no issues there. She does have some dry skin on her lower legs, but no rashes, nothing like that. And she does endorse some feelings of loneliness, but denies any anxiety. For her physical exam, she's alert, she's oriented, she's sitting on the exam table, she's in no distress, she answers questions appropriately, she's thin, she does smell like cigarette smoke, her sclera are white, she is wearing glasses, mucous membranes are moist, her neck is supple, no lymphadenopathy, her respirations are smooth and unlabored. There are some wheezes noted posteriorly on expiration, which she says is pretty common for her. On auscultation, the heart rate's regular rate and rhythm, no extra heart sounds. Her abdomen is flat and soft, no masses, no pain on palpation. Bowel sounds are present times 4. She does deny any suprapubic tenderness on palpation, and she also denies any CVA tenderness on exam. She moves all of her extremities with good active range of motion, no deformities, no deficits. Her gait was steady when she came in and when she left. There no edema to her lower extremities. Like I said, she's alert and oriented. Her movements are smooth and coordinated. Her thyroid gland is palpable and soft, it's smooth, it's symmetrical, non-tender, no nodules. So her skin is warm, dry, and intact, appropriate color. Like I said, she does have some dryness to lower extremities, and she does express some loneliness. Lab tests. So I reviewed her lab tests from December of 22, which were her last lab visit. There was nothing really abnormal. They're all within normal limits. But today, because of her urinary complaints, we did a UA. Her urine was cloudy, and it was positive for nitrates and leukocytes. So being that those were positive, we did do a reflex for CNS, and we'll follow up as we get those results. So our primary stressors, she has an irreversible chronic health condition, which is COPD. It's physiological interpersonal stressor. Her COPD has penetrated her flexible line of defense and her normal line of defense and central core, affecting her breathing and causing shortness of breath, which is a result of organ damage. She also reports feeling of loneliness, so that would be a psychological and interpersonal stressor, which has penetrated her flexible line of defense and her ability to cope with situations, as evidenced by her feelings of loneliness, which has, disrupted her internal environment or interpersonal. She continues to be a current everyday smoker, which would be a physiological, sociocultural, and interpersonal stressor, which has also penetrated her flexible line of defense, as it's her crutch, kind of her ineffective coping mechanism to her dealing with her stress and loneliness. So our differential diagnosis would be urinary tract infection. Findings that support this diagnosis are she's female, she has a history of UTIs, she's menopausal, she reports foul-smelling urine with burning during urination, and her UA is positive for leukocytes nitrates, and is also cloudy. There is no negating evidence for this diagnosis. The second differential diagnosis would be genitourinary syndrome with menopause. Evidence supports this diagnosis is dysuria. She's a female. She's menopausal. She smokes and uses alcohol. She has decreased sexual frequency as she's not in a relationship. Evidence that excludes this diagnosis includes she has no pelvic pain, no vaginal dryness or itching, no vaginal bleeding, and the fact that her UA is positive for leukocytes and nitrates, and her urine is cloudy. The third differential diagnosis is acute pyelonephritis. Evidence that supports this diagnosis is dysuria, and the UA is positive, again, for leukocytes and nitrates. However, this diagnosis is ruled out to the fact that she has no fever, she has no CVA tenderness, headache, and her UA is negative for blood or protein, and her urine pH is 6.0. Interventions, management, and competency. So treatment of infection with antibiotics using the evidence-based practice and direct clinical practice, which would be secondary prevention since the infection is currently present. We would increase our fluid intake and hydration to 2 liters a day, which is primary prevention initiated through expert coaching and supported by evidence-based practice. We would make sure to she should make sure to completely empty the bladder when voiding. Evidence-based practice supports this, and we use expert coaching guidance to teach her this, which would be another source of primary prevention. Another teaching would be do not hold urine, use the restroom when prompted. This is also supported by evidence-based practice and provided through expert coaching and guidance, and is also a form of primary prevention. Another primary prevention that is supported by evidence-based practice is perineal hygiene. You want to wipe front to back and avoid bacterial pathogens from entering the urethra. Supportive literature for decision making is here with the citations. I use Dumphy and I use Ollier clinical guidelines. So outcomes that we would expect, 2G will become symptom-free after 72 hours of antibiotic therapy and require no follow-up appointment. Will complete the entire course of antibiotics, and she'll report an improvement in her mood at her 1-month follow-up appointment after the 1-month start of her Lexapro. We started today. So for hypothesis, she should have resolution of symptoms within 72 hours with her completion of her antibiotics. Her dysuria and urine odor should subside with antibiotic completion. Unless something changes symptom-wise, she is not required to follow up in the clinic. We'll review her urine cultures as we get them back, and if antibiotics need to be adjusted, we will call her. Otherwise, no news is good news. So follow-up. No follow-up, like I said, should be needed. However, if she does experience persistent or worsening symptoms and the UTI does not resolve as expected, we'll do a repeat culture. May change her to Levaquin 750 PO daily for 5 days. If the UTI becomes complicated or worse, we may consult urology. If there is resolution of symptoms without complication, we will see the patient back in the clinic in 1 month, and that's when we'll evaluate her new onset of mood changes, and that'll be 1 month post starting Lexapro. We will also follow up with gastroenterology referral since she's due that colonoscopy. It's been 11 years. And we will discuss smoking cessation again and at each consecutive visit until she's ready to quit. Ideally, she will complete her full course of antibiotics and have no other complaints.